Welcome. Thank you so much for coming.
Thank you so much. Hi, everyone. My name is Lynda, and it's lovely to be here, quite humbling to be here as well. I'm going to talk to you today about managing prediabetes in Black, Asian, minority ethnic groups. And before we start, I'll tell you a story about a patient that I've seen. This is a man, middle-aged man. He stuck with me because we had conversations where he had this was being reviewed for his third diabetic medication, and the picture of very high HbA1c and CKD as well. And then I said, let's go down to the basics because I'm seeing him for the first time. What does it look like for you in terms of the basics of exercise, diets, and things like that? And he looked at me and laughed and said, I can't eat the carrots and the cabbages and the salads, you know what I mean? And he said it to me in the context of me being a Nigerian, a black person. And I said, yes, I know what you mean. I know you want your fufu, and I know you want your eba, and all of that. So we laughed, and then when I said, what if I told you there were resources that could help you meet, reconcile that difference? And then I told him about the Diabetes UK resources that could help him. It didn't solve all the problems he had, but you could see the relief on his face to have that gap bridged for him. And when I thought about that going forward, it was the fact that if it wasn't me and he met someone else, the care could vary, right, across the system in terms of what kind of support do we give patients who've got prediabetes from BAME communities. So my question to you today to reflect on while I speak is, what do you do with prediabetes for patients from this population, right? And the focus is on looking at how we make every contact count, because primary care is quite unique that we see these complexities. We don't have time to address all the complexities, but it's about how do we add more value within what we have at our disposal. So as a context, we know that prediabetes is about 6.3 million people across the country. We know that the NHS spends about 10 billion on that every year. And it is the highest cause of blindness in a working age population when it becomes diabetes. Going by curves, which most practices will focus on when you look at levers for making change, the thing we have there is that this patient should have their HbA1c checked every 12 months. And the whole idea of doing that really is case finding, but case finding to intervene. Now what happens is, when we are finding cases and ticking the box, but what next? It varies across. Some people would go ahead to refer to NDPP as per NICE guideline, but not everybody gets that. So what can we do in terms of brief intervention within our primary care focus to be able to support these patients in their journey? There's another interesting data from NIHR, which pointed out that non-white patients are more likely to be referred to NDPP, but interestingly, are more likely to drop off along the way. When they go through that cycle, they still come back to primary care. They still have their problems, and how can we meet that need for them? If we're not thinking about this in this context, what happens is every year we tick the cuff box. They've had their pre-diabetes HbA1c rechecked again. We do that for 5 years, and then they become diabetic, and we start managing diabetes. Is that really the reason why we have those numbers to be checked? I think the answer really resonates that that's not the reason. Sorry, I don't know whether... So what I did in my practice, basically, being a GP registrar, the power and influence in any organization that you are situated in isn't the same like you would have as a GP partner. And also, it's very short time, so it's 6 months to 12 months if you're in ST3. So it was about finding that data in our practice that can lead us towards change. And it was about bringing that in a way that it is visible, that we can leverage it for change. So we looked through the data for our patients with pre-diabetes, and we thought to look at it from a NICE guidance lens. And what we saw was, we were doing some things right, we were doing the case finding and repeating it every year. But in terms of supporting them with with written resources and referring onwards to NDPP, it was quite varied. So we identified that as a lever for change, really. And then looking at, if we're making this change, how can we also make sure that we're picking up these people who are more likely to struggle with reconciling the advice from NDPP or from any generalist resources to what they experience in their homes. So what we went ahead to do was, we also looked at additional cultural responsive resources that we use. And we saw that we were really doing well with referring them onwards to We're doing well with using the translator support to be able to support the consultations. But again, I don't think that generally in the NHS we've got written resources that are in other languages. We do have that for awareness about the NHS health checks, but not the NDPP. But we did find out that the NDPP programs had a virtual option with multiple language options as well. So you could request to have it in Urdu, you could request to have it in Punjabi in a virtual setting. It's not the best in terms of the fact that some people would still prefer to have face-to-face encounters, but it was still something to work with. So mapping all the resources that we could find, we created an action pack that we could give these patients. And we tried to look at the fact that we had a diverse growing population in Wigan, in the sense that about 5 years ago, if you asked people, they would say, my child is probably the only black child in their class or the only Asian child in their class. But now we have lots of children, and it tells you about how that growing population needs are evolving and being able to meet that need in primary care. So creating the action pack, we took it forward and created a pre-diabetes corner on the practice website. So these are all things we've done with no additional resources, but just thinking around how do we create more value and make it more accessible for GPs or GP registrars to be able to signpost patients. Using that link, we then created the Accurate template. So literally, if we did a mapping of the pathway before and after the change, and what it meant is that we could then get patients at the point of diagnosis. You send this link, which now has these resources. It has a video that has been recorded by the GP partner in that practice, explaining pre-diabetes, and then calling them in to come have an appointment with the nurse and then take it forward from there. This is in contrast to the status quo, where it would have been a normal text message going out to say, you've got a result for a non-urgent blood, book a non-urgent appointment. And that is left to the transcription of whoever is receiving that message. So what I wanted us to think about today really is the power of the ideas, concerns, and expectations we get out from our patients in that consultation room where they confide in us, and what more can we do with that data. And also, when you pick up these trends, it's an opportunity for us to think about the fact that this might be a bigger picture. And then also thinking about the fact that existing pathways, existing ways of working might have just few things we need to switch around, and we will probably be adding more value to those patient needs. And one thing I learned on the journey of doing this project was that I can't use the word culturally competent for my patients, because how do I become culturally competent in a culture that is constantly evolving and I'm not embedded in it? So it's about patient-centered focus, engaging with that patient and asking, humble curiosity to say, what do you need? What do you need to get you from point A to point B? And thinking about what wider resources we can equip them with to be able to meet their needs. And this isn't just about pre-diabetes, it's about every lifestyle condition that when we ask people to make changes to their diet, it reflects on the whole family. I'll give you an instance. I ordered a HelloFresh box recently. I loved it. My kids had me make them something new because they just didn't want to eat it. So it's important to really meet patients from this perspective, supporting culturally responsive care so that they can be able to make the change that they desire for their health. Thank you.